Hello, everyone. I'm Ron Rolfing, and I'm the Preferred Vendor Coordinator here at ACAP. And I'd like to welcome you to our latest ACAP Vendor Education Series webinar presented by ACAP Strategic Ally, Softheon. Our presenter today is Kevin Deutsch, General Manager and Senior Vice President of Health Cloud Plan at Softheon. And he will be presenting the webinar Healthcare Consumerism 2.0. From employer-sponsored coverage to ICHRA. But before I turn it over, I do have a few housekeeping items I need to take care of. This webinar, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines, and these guidelines can be viewed on our website. We will be recording today's call, and we'll post the slide deck and recording on our website by tomorrow morning. The link to these items can be found in the invitation sent to you for this webinar. And please remember, if your plan is looking for a vendor, be sure to check out our list of preferred vendors on our website. Just look to the top of our homepage and click on the preferred vendors link. And of course, during the call, you can ask a question at any time. You can do this by clicking the Q&A icon at the bottom of your Zoom window and typing in your question. And all questions will be answered at the end of the presentation. Now, I'd like to pass it over to Kevin.
Thank you so much, Ron. And thank you to the ACAP team for always being such great hosts. I know that this is our second webinar in the past couple of months on some really impactful topics. Last month, we focused on interoperability, and today we're here to talk a little bit about Consumerism 2.0 and the impact of ICHRA. It's crazy to think that we're a week away from Christmas. This has been maybe the longest year in history, and then it feels like it went by in a flash. So for those of you that are tuning in from the Northeast, I know we experienced some snow. There's about 6 inches here in Long Island, and it's been a few years since we've last had a real good snow, and I know others got even more than that. So I hope everyone is safe and warm inside, and I think it's one of the beauties of working from home is that you don't have to deal with all of the roads and the shoveling and things like that, because you stay in your home office and take care of what you need to. So thank you all for taking the time to meet with us today. As our world continues to shift around us, we're starting to see major shifts in our healthcare system as well. The most recent news is the creation and distribution of a vaccine for one of the most deadly viruses that we've ever had in the history of this country. We're seeing things change in interoperability and price and cost transparency. And now we're looking at a transition in the White House from President Trump over to President-elect Biden. There are so many things that are continuing to change in healthcare, which is driving this concept of consumerism that we're here to talk about today. And prior to the pandemic, we were introduced to probably the best kept secret in the industry right now, which is known as individual coverage health reimbursement arrangement, or ICHRA. Now more than ever, ICHRA is something that is going to end up being critical for employers and employees to allow for greater access to care for as many individuals as possible. I'm really excited today to talk to you about ICHRA, the shift that we're starting to see in the commercial mix, why ICHRA is so important and why it should have meaning to those of you that are on the line with us today. And then we'll look at some of the key components to Consumerism 2.0, and we'll share from the Softheon perspective what that may look like. In speaking with a health plan executive just a week ago, we were discussing the concept of ICHRA, and they mentioned that by switching to ICHRA, their hospital system is saving upwards of $300 per employee per month. Now, this hospital system that I was speaking to has about 2,000 employees, and if you do the math over the course of a 12-month period, there's over $7 million in savings for this hospital system as a result of moving over to ICHRA. And this is just an anecdote that I wanted to share with you all as we set the stage for what it is to come. And when you think about cost savings, especially for employers during these very difficult times, it is so important that if there's ever a place where costs can be cut, this could be an opportunity for employers. And we'll talk about the benefit to the employees as well. As we further set the stage here, I had actually presented a webinar several months ago with our partners at Oliver Wyman, where there was some research conducted in what the commercial mix may look like. And we did this back towards the beginning to the middle of COVID to where we would be at the end of 2020. As you can see here, there were some baseline metrics, and then there were factors considered based on the unemployment rates in this country. I know that at one point we were upwards of 20% unemployment, and now we're stabling at around 6.7%, which is the latest metrics that I saw. So fortunately, now that we're at the end of 2020, we're not seeing the unemployment rates that may have been projected, which would have led to the shift as is indicated here. But one thing that I do want to call out that has been consistent, and you'll see it in this graph, is the shift from employer-sponsored coverage into the individual markets. And you'll see individual and, of course, Medicaid for those that are no longer eligible for the ACA and they end up enrolling in a Medicaid plan. Those numbers are continuing to increase while the trend is starting to go in the opposite direction for employer-sponsored care. And there's many reasons why that's occurring that we'll talk about here in just a moment. So while these specific projections aren't exactly where they ended up because of the fact that our unemployment rate is not at 30% at the end of 2020, we are absolutely seeing a shift from that employer-sponsored care into the individual market. To speak in a bit more depth, for those of you that participate in the federally facilitated marketplace, or the FFM, the 45-day open enrollment period for 2021 coverage had just ended on this past Tuesday. The snapshot that we have here today is from acasignups.net, which has some interesting information to track data associated with enrollments for the 2021 plan year. And what you could see is the trend is rather consistent when you think about the individual enrollments during the open enrollment window, where you see it start somewhat slowly, and then it'll pick up around Thanksgiving. And then, as we are human beings that like to procrastinate, folks will go out on the last day, which is December 15th, and enroll in that January 1st coverage. So you can see that the trend has been consistent. And the green section will represent those that are participating in the federally facilitated marketplace, and then the blue region would indicate those that are in state-based marketplaces. And you continue to see a trend from the FFM into individual state-based marketplaces. And the reason we're talking about this is to show that growth in the individual marketplace. What you could see is the daily enrollments had increased in 2020 for the 2021 plan year by 4% from November 1st up until this was captured on December 9th. Now, this includes Pennsylvania and New Jersey. And for those of you that are following along, Pennsylvania and New Jersey in 2020 were on the FFM, and they have since moved to their own state-based exchanges. So if you actually exclude Pennsylvania and New Jersey, we saw an increase of 11.1% enrollees into the individual marketplace for 2021 coverage. Another thing that I thought was interesting that I wanted to point out, which shows the stability of the individual market, is the 16.5% increase in plan renewals. Now, there's been quite a bit of churn over the years of ACA in open enrollment. And what we're noticing this year is that consumers are actually becoming more comfortable with their individual coverage and their health plans, leading to this increase in renewals. It's a sense of stability for these individuals that may not have had coverage previously, and now they're understanding the benefits of ACA and making sure that they have their health insurance, including the fact that the premiums have just about stabled across the board. So this is just a brief snapshot of open enrollment for 2021 and what that may mean to those that are interested in getting into the individual market, and better sets the stage for the shift that we're talking about from employer-sponsored care into individual coverage. And I am certainly no scientist, but I thought that this image was a perfect depiction of this convergence that we're speaking of. And when the tectonic plates shift, we have a volcano form. And you'll see that right at the central point of that collision between individual coverage and group coverage is the intersection of brokers, employers, and employees, all tied together by health plans. And each of these stakeholders have a major role in this convergence and the ability for these two worlds to coexist together. And if the tectonic plates weren't shifting enough prior to COVID, I can say with certainty that COVID has certainly accelerated this movement and furthered the convergence of individual and group coverage. And we'll dig into that a bit further, some of those factors that may cause this shift to occur. Now, it's important to define where we were and how it ends up getting us to where we are today. Going back to 1974, HRAs was actually introduced back then, and it created models for employers and payers to use pre-tax dollars to pay for healthcare expenses as well as healthcare premiums. So HRAs are not actually a new topic. They've been around since the 70s. In 2000, the IRS made some updates to better put the customer central, and we'll talk about what that means here in just a second. And it further allowed employer flexibility as it relates to the way that they're administering healthcare benefits. Fast forward to 2013, it was the birth of ACA and the first ever open enrollment, allowing individuals to enroll into their individual health plans under the Obama administration. Shift even further to 2016 and the Trump administration. You have the introduction of the CARES Act, or the Cures Act rather. And the Cures Act is what allowed for the introduction of interoperability and some of the rules around price and cost transparency. And it also included the introduction of QSARAs, and we'll talk about the difference between the ICHRA and the QSARA, but this is where it was introduced under the Trump administration. And lastly, in 2020, we have the introduction of individual coverage health reimbursement arrangements, or ICHRA, also under the Trump administration, to further solidify this individual marketplace. And that sounds a little bit like an oxymoron when you think about it, because of the fact that a lot of the narrative was around repealing and replacing the ACA. However, you could see some of the actions that were taken during the Trump administration was to further solidify the individual market with the introduction of QSARA as well as ICHRA. Digging a bit deeper now into the definitions and the shift that we continue to talk about. For an ICHRA specifically, it's individual coverage health reimbursement arrangement, or also known as an individual integrated HRA. What this is employer-funded, tax-advantage health benefits used for employees to reimburse qualified health expenses as well as healthcare premiums. For other HRAs, there is a cap size of the number of employees that are able to be utilized for this program. For ICHRA, it's available to businesses of any size, from 1 employee up to 1 million employees. And for a QSARA, or a qualified small employer health reimbursement arrangement. The difference here is that these are subsidies that are allowing for employers with fewer than 50 full-time employees to be able to participate. There's a cap to the number of members that are able to participate in the QSERA. And there's other differences that we'll talk about here, but we wanted to just make sure that we set a basis, including the definitions for each of these different programs. ICHRA, and I've been personally following ICHRA for the past several months, even going back to the end of last year, and it's something that we've really been keeping a close eye on. Some of the key aspects of an individual coverage health reimbursement arrangement is that this is truly a defined contribution. One of the challenges with employer-sponsored care currently is that employers have a tough time budgeting because of the fact that the amount of dollars that are spent on a monthly basis are based on the different enrollments for individuals and what plans they are specifically selecting. With an ICHRA, the employer will set a specific defined contribution that won't change month over month and allow the individual to go and purchase their own health insurance. It's a very, very critical point to note that this defined contribution allows for the employer to have a more budget-focused approach that doesn't vary month to month. And I'll continue to beat this to death with how important that is, considering the current landscape and employers doing everything they can to just stay above water with all of the restrictions that they're under, to reinventing how they're doing business. Healthcare is the last thing that is currently on an employer's mind. With ICHRA, as we mentioned, it's open to all employers, regardless of size. Whether you have 1 employee, 1 million employees, it doesn't matter. Everyone is able to participate in ICHRA. And what's interesting about ICHRA is that you can break down your employees into separate classes, whereby you may offer the group insurance to one defined employee class, whereby you may offer an ICHRA to another, and you may set a different contribution for one class versus another. And on the next slide, we'll talk a little bit more about the different class options as part of an ICHRA. And lastly, and what I think is probably most important for ICHRA, is the impact to the employee, whereby the employee can either choose to take their ICHRA or defined contribution from their employer on a monthly basis, or they can elect to receive their premium tax credit that they may be eligible for. There's an affordability calculation that will determine which one is considered more affordable for the consumer, be it the ICHRA or the tax credit or the subsidy through the federal government. And you can see a brief timeline here for ICHRA, that the final rule was released middle of last year, and this has started for the plan date effective January 1 of 2020. So it's almost been a year now of ICHRA being in motion. And while the adoption has been slow thus far, we are starting to see it pick up more and more. And we have some data to share with you as we continue to navigate this presentation. As we mentioned, the different employee classes, there's a total of 11 different employee classes that employers can designate their employees into, from full-time to salaried to non-salaried, temporary employees, and the like. And based on the employer size, there's different requirements for the minimum class size that you can designate. So for example, if you have 100 to 200 employees, you're capped to a 10% minimum. So these employee classes allows for even further flexibility from the employer to be able to build a plan that is customized for their employees, whether it be a group plan as they're used to today, or it's adding the temporary employees and allowing them to spend their premiums on their own individual coverage as opposed to getting locked into the group plan. And we're starting to see that the larger employers are looking at that for their temporary or non-salaried employees. So while they may offer a group plan for those that are full-time, for seasonal or part-time or temporary employees, they're going to the ICHRA, as we mentioned. A brief comparison between the ICHRA and the QSERA with a little bit more visuals. As you mentioned, the QSERA is limited to 50 employees and less, whereby ICHRA, there is no employer size. For QSERA, there is a maximum contribution. For self-only plans, it's about $5,400, and for families, it's a little over $10,000 that are able to be contributed. For QSERAs and ICHRAs, the QSERA is eligible for a premium tax credit. There is a calculation that determines how much you could take for your HRA versus your tax credit, whereby ICHRA, it's one or the other, as I mentioned, based on the affordability measure. So I hope at this point, it's making a little bit more sense as to what it is that's a QSERA, what it is that's an ICHRA, and starting to formulate the reasons why we may start to see a shift from the employer-sponsored coverage into the individual coverage. And I will continue to drive this point home is that everything that we do at Softeon and in any health plan that I've ever worked with, the consumer is first and the consumer is central. And in this specific diagram, we're taking you through that brief consumer journey for ICHRA. And the consumer could be the employer. The consumer can also be the employee in this case. And basically, the simple workflow here is the employer will designate their employee classes and set their defined contribution into each one of those buckets. Once they do that and they notify their employees, the employees will go out to either the federal or the state exchanges or even to private exchanges and purchase the individual coverage that best meets their needs. Once they do that, and once they have any other qualifying healthcare expenses, the employee would ultimately pay for that, and they will submit documentation and receipts to their employer for reimbursement. And then the employer will reimburse the employees for claims that are valid and, of course, within that defined contribution. This is the very, very high-level rudimentary workflow when you look at setting up an ICHRA and then ultimately fulfilling that ICHRA. And as we look at Consumerism 2.0, when we progress through this discussion today, we'll look at some alternatives to this workflow and some variations that may even improve the process along the way. This is the shift that we're starting to see. Now we'll talk about why is ICHRA important? Why should you as a health plan executive and an ACAP plan be interested in ICHRA? Why are employers interested in this? And why should employees be excited about this as well? Just looking at the numbers alone, there is an incredible opportunity here. Based on allowing for ICHRAs to be introduced, there is about 800,000 uninsured who will be able to now obtain coverage as a result of the introduction of ICHRA. There are employers that weren't previously involved in offering group coverage that are now able to do so. And believe it or not, it's the same number. There's 800,000 employers that are now able to offer insurance to their employees when they couldn't do so previously. And then you have now 11 million employees as a result of these employers that have this option available to them that are able to go and purchase health insurance whereby they didn't have this option available to them previously. And lastly, to look at our total addressable market, there is 160 million employees that are currently on employer-sponsored coverage that now have access to an individual plan if they were to move over to an ICHRA. So this is just setting the stage for the market associated with ICHRAs, and we'll talk about why it's important and why we're going to continue to see this trend. I think everyone is familiar with this, and for those that are administering employer-sponsored care or those that are provided employer-sponsored care as an employee, year over year, we're continuing to see the premiums rise. You could see that the premiums in 2009, 13,000, now capping out at 20,000. The numbers continue to increase year over year. And what that's causing is a greater burden to the employer that's funding these employer-sponsored plans, and it's a greater commitment for the individual or the employee who is contributing to these employer-sponsored plans. You could see that we use the term unsustainable. I think we would all agree that the way that this trend is going is unsustainable, especially in the times that we're dealing with now, which makes it even more important to consider something like an ICHRA, which brings us to the opportunity that we have. The previous chart was showing just what the premiums looked like in 2019. In 2020, there was another 6% increase in the premiums for employer-sponsored care. As we mentioned, the average premium for a family plan, $20,000 for that employer-sponsored coverage. Now, one thing that is really beneficial and exciting for the employees is the plan choices. When you have employer-sponsored care, there's only a handful of plans that are available to you to choose from. And considering larger organizations, they're not customized to meet your specific needs. So you may be forced into a plan that may not have exactly the plan design that you may be looking for. So you could see that as of this chart that we have here, for employers that have less than 200 employees, 81% of those have only one plan option to choose from. When you think about the hundreds of plans that you can choose from on one of the exchanges with individual coverage, it's really staggering. And the other 19% have more than one. Now, when you look at employers with 3 to 9 employees, they're not offering insurance at all. You could see that 53% of them do not, whereby 47% of them do. And that's where some of that market had come in that I had spoken about earlier, and the opportunity that lies in front of us. So you can see here that there are certainly benefits to employer-sponsored care, and there's limitations. And when you think about ICHRA, there's an opportunity for everyone to be able to win. So we'll go through some of the key stakeholders. If you remember from the slide earlier on with the volcano that's forming, you have this cross section between the brokers, the employers, and the employees. And all of that is tied together by the health plan. The health plan is ultimately creating the plan designs and offering these individual plans for folks to enroll and obtain healthcare benefits. So some of the key points where we make this statement that everyone can win with an ICHRA is the broker community. The brokers can either establish an exchange where they're able to enroll their consumers, or they can build relationships with both private exchanges as well as the health plans directly to facilitate these individual enrollments. As the individual market continues to gain popularity, brokers are becoming more and more comfortable with the tools that are available to them to be able to enroll individuals. For the employer has the flexibility now to create employee classes. Maybe you offer a group plan to one class and you offer an ICHRA to another. So the employer has that flexibility. I can't reiterate enough the importance of the defined contribution, whereby month over month, their budget will remain consistent. And what the employer is able to do is make monthly payments to the issuer on behalf of their individuals. And we'll talk a little bit about some solutions as we go forward here. And central to everything, the employee. The employee now has portable health insurance. Regardless of the relationship with their employer, they're able to maintain the health insurance and build that relationship with their health plan. That's the beauty of the individual market, is that the employee is getting more exposure to the health plan and is in greater control of what it is that they're administering their plans. They can utilize things like payroll deduction as an option to pay for this care. So as opposed to fronting the premium dollars, they can set up a payroll deduction through their employer to be able to have their premiums paid and funded through their ICHRA. And as always, the employee is central to these conversations. Folks that may not have had access to healthcare previously, no matter what that minimum contribution is that the employer can make, they can go out and they can purchase health insurance, and they didn't have the option to do that previously. A brief chart comparing the employer and the employee to talk about some of the details of how they can ultimately win in this environment. The employer can focus on their business instead of healthcare benefits. This is something that, and that's why many of the employers are utilizing a broker, because it's too complex for them. They don't want to spend the time to focus on building a healthcare plan that's going to work for their employees. So now they can focus on, many of them, reinventing their business as a result of COVID. They can set the defined contributions, whatever works for them in their budget, as opposed to being locked into setting up group plans and then paying based on the plans that their employees are enrolling into. So budget conscious decisions. It is compliant, ICHRAs, with the employer mandate. So if employers are required to offer health insurance, by offering an ICHRA, you are complying with that specific mandate. And as I mentioned, employers have the ability now to offer health insurance when maybe they could not do it previously. Employees, the choice in the number of plans is a major criteria as to why this is so important to them. As opposed to being locked into the 1, 2, or 3 plans, they can go out as a consumer and they can shop for the plan that meets their individual needs. That's the greatest beauty of all of this. Not only are we balancing the cost of care, we're also allowing them accessibility into more health plans and choices that are going to best fit their needs. The ICHRA actually qualifies for a special enrollment period. So if the employer was to set up their ICHRA in the middle of the year, for example, it would qualify for a special enrollment period, and the employees could go out any time of the year and apply for coverage and enroll into an individual health plan. As I mentioned, the portability is a critical factor, that the employee can be more tied to the health plan as opposed to the employer themselves. And decisions, they have more control over the premiums that they're paying. They make the decision, do they want to enroll into a platinum plan or do they want to enroll in a bronze plan? They're not stuck to the 1, 2, 3 plans that their employer may make available to them that they truly cannot afford for both themselves and for their family. And to the health plan leaders that are out there, how can you win in this conversation? Well, first and foremost is you're able to retain employees that are currently enrolled as part of your group plans by enrolling them into your individual products. And it will no longer require them to be employed by their employer in order for them to stay within your plan. So that's the first benefit. The second is, as with everything, there's an increased focus on the individual consumer and building that relationship and building those touch points along the way. By removing the employer as the middleman and those group plans in the middle of everything that's going on, you have the ability to connect directly with that individual consumer, from the way that they enroll in your plan to the way that they continue to engage in care coordination and things of that nature. The product designs, as the health plan, you could focus on your individual products and allowing those ICHRA-enabled plans to be put into the marketplace, whether that be on exchange or whether that be off the exchange, but you could focus on your individual products. Right now, you may have multiple different solutions to support the health insurance that you're providing. You may have one whole IT stack dedicated to your small group processing, whether that be billing, whether that be payment collection, whether that be enrollment and shopping. You may have one set of rules for small group. You may have a whole other set of rules for individual. By adding ICHRA, granted there's certain differences, but it's individual health insurance at its core. So you could simplify the overall solutions as part of your infrastructure, meaning that you can leverage some of the processes that you've built on the group side or that you've gone to a partner to utilize, so that you can leverage that in this solution for ICHRA. And when we get into our consumerism section here in just a moment, we'll talk about what that means for billing and payments and some proposed solutions that we could see. Now that we've set the stage for the shift that we're seeing, why ICHRA matters, we'll look at Consumerism 2.0 and what that means to us at Softeon and what that may mean to the industry. As I know everyone will define this term differently, but we feel that ICHRA is really central to this next level of consumerism. And we'll talk about some other things that may contribute to this as well. Number one is we have a new president-elect. There will be a new administration effective in January. And the image that you see here on the screen is actually from a tweet from President-elect Biden directly, where he's promising several things that you've actually heard over the past several years, including lower premiums, deductibles, and drug prices when we talk about cost transparency. We may see a public option get introduced. This will be another level of consumerism, where you may have a public option and you may have your private insurance, that they remain diligent in saying that you'll be able to keep your existing insurance. And the end goal for everyone to be able to have coverage. And we think that ICHRA is absolutely a vehicle to that. So Biden Care is something that we're going to keep a really close eye on over the next several months. We'll see what happens with the Supreme Court decision, and then what that means for the future of ACA as we transition into something like Biden Care. Now, this may seem a little bit strange. You may be saying, well, less centralization. You would think that it's the opposite with the new administration, but we're continuing to see the trend away from this healthcare.gov FFM model and more into the individual state-based exchanges and private exchanges. So when you talk about consumerism, they're not stuck to one mall. They can pick the mall that they shop from. They can go to the individual health plan. They can go out to their state exchange, which is a little bit more personal to them, as opposed to this FFM and healthcare.gov type model. Interoperability is a major topic. We just hosted a webinar last month on this very topic. It's very, very important. And then, of course, price and cost transparency, which is directly related to interoperability and making that data available so that consumers can make informed decisions about their healthcare. I think we'd agree that one of the biggest challenges in healthcare is that the consumer really doesn't have any skin in the game when it comes to making some of these decisions. And the same holds true in the employer-sponsored care, as opposed to ICHRA, where you're really putting the power into the hands of the consumer directly. This is maybe the part that I'm the most excited about, which is, what does the solution look like? What does the ideal ICHRA solution look like? We talked about what it is. We talked about why it's important. So where do we go with it? How do we actually implement these solutions? So there's a few key components. And it starts with the decision support aspect. And when we talk about decision support, we mean the ability to help a consumer make a guided decision about what is best for them. And this is both for the employer and the employee. The employer needs tools to be able to determine what's more affordable for my organization. Is it offering ICHRA or is it offering the group plans? Based on the employee classes that I designate, what is going to be best for me? The employer needs to be able to set up their group and get their census loaded. They need solutions to be able to do that. They need solutions to be able to modify their census as changes occur with their employees. The employee needs the ability to enroll into these individual plans, including enhanced direct enrollment or EDE. And for those of you that are not familiar with EDE, it's the ability for an individual to get a subsidy on a health plan site directly, as opposed to going to healthcare.gov. Again, further solidifying this concept of consumerism and having the member be central to everything that's happening to streamline the overall process. When we talk about the brokers need to be able to enroll these individuals, and they need to be able to modify their plan selections, and they need to be able to make payments. They need to be able to administer invoicing. The broker plays a very critical role here. Integrated billing and payment. This may be the most important of all, is the ability for there to be solutions that exist that allow for the employer as well as the employee to be able to make effective payments under this model. And there's solutions that exist that I know that we're even working through that will allow for the employers to remain involved and be able to administer payments out to the health plans without relying on the individual to take control of submitting their monthly payment. Because as you all can imagine, fronting the cost of health insurance is a major challenge with ICHRA. If the employer is no longer making that payment, or if there's no payroll deduction in place, it assumes that the employee is able to front those dollars and then ultimately submit for reimbursement. And of course, with any solution, we need to have the appropriate reporting and analytics in place to continue to tweak our process and make it just a little bit better. The personas, we continue to speak about the employer, the employee, the health plan, and the broker. Here are some suggestions that we have for each of these different groups. For the employer, either through the issuer directly or through some exchange, the employer needs the ability to set up their defined contributions. They need the ability to establish their employee classes and ultimately place those dollars in the appropriate buckets. An ideal solution for the employer looks at being able to make automatic contributions into these ICHRA plans, if you will, and the ability to self-serve and make changes to your employee census as things change. So that's no different than what you're seeing in the existing employer-based care, but the employer now with ICHRA needs to be able to designate where those defined contributions go and make changes to their census as things happen. For the employee, when they're enrolling into these plans, they need solutions to be able to compare what's going to be more affordable through the affordability measure. Is it the ICHRA or is it the APTC? And I know recently, as an enhanced direct enrollment partner, we've had to build in logic into our platform to be able to calculate and ask these questions about, do you have an ICHRA from your employer? And that'll determine whether they get the APTC or they continue and take the ICHRA as is. So that's another component to all of this. The employee, this automatic reimbursements, as I mentioned, is also very critical and central to this conversation. The employee needs to have a process by which their employer is able to either automatically reimburse them, or the employer is able to deduct the funds via payroll deduction to the employee to reduce the burden on what the employee has to do directly. For the health plan, you ultimately need these tools to be able to support the employers and the employees who are enrolling, and then ultimately be able to conduct the billing and the payment collection. The ability to administer these actual ICHRA accounts is something that needs to be considered. And one thing that we've seen health plans continue to do is to place these plans onto the private exchanges. There's web-based entities that are out there that are looking to house your specific plans so that folks can enroll through a variety of different locations, whether it be coming to your site directly or going out to one of these exchanges to enroll. And of course, the broker, their job gets a little bit more complex as they look at working with all of these individuals directly to enroll them and place them into the individual health plans. So they need to make sure that they're engaged with the private exchanges and with the issuers directly. I'm going to give you a brief snapshot of our mobile application that is applicable to Consumerism and ICHRA directly. And this is our direct-to-consumer brand, Well, who I know that they had recently done a webinar on ICHRA also. And what they're doing is we are considering mobile friendly first. And what you could see here is a brief decisioning tool for the employer to go out and ultimately designate their employee classes and their defined contributions, which you can see in the next screenshot here. And then finally, upon completing their employee classes and contributions, there's a trigger out to the employee to go and enroll in their individual health insurance. Now, this is an application that we're in the process of building to support our direct-to-consumer line. However, if you think about it, this could also be applicable to the health plans directly, whereby the health plans can encourage their employers to set up this ICHRA and ultimately notify their employees to enroll in ABC health plan. Now, granted, the employee can go out and they can shop and they can find other plans, but this could further encourage employees to stay with their existing health plan as opposed to going out to a marketplace and continuing to shop. With everything, there are barriers to adoption, and COVID-19 is certainly one of them. And we're seeing that ICHRA is still slow to pick up. We're getting there slowly but surely, but we do believe that COVID had something to do with that because, as I mentioned, businesses are really focused on redefining how they operate and their operating models, and individuals are really focused on staying afloat. There's many stakeholders involved, as we talked about here, that will end up driving the adoption for ICHRA. And because of how many folks are involved, there could be the case where everybody points the finger at the next and nobody actually takes the action to establish ICHRA. So that's when you ask the question, who owns the actual solution? Is it the technology enablers who are getting involved and really push this forward, or is it the health plans, the employers, the web brokers, so on and so forth? We question whether the affordability is actually in the best interest of the consumer. Will they end up taking the ICHRA because it didn't meet the unaffordable measure when the APTC may have been better? Those are some things that we're still questioning. As you mentioned, the ability for the individual to front the premium payments, that could also lead to slow adoption. And there's still many solutions that are being vetted. I know that there's companies like Softeon and other technology companies that are really getting into ICHRA and looking to build some of the solutions that we had spoken about previously, but all of this is still very much under construction. And when you think about what's next for ICHRA, some metrics to share, and this was according to a Willis Towers Watson survey that was recently administered. 15% of employers are expecting to get into ICHRAs in 2022 or later. We feel that 2021, there will still be many of the remnants of COVID, but hopefully by 2022, we continue to see adoption into these ICHRA plans. Some other metrics, 30% in the public sector and education, 22% in wholesale and retail are planning to offer ICHRAs 2022 or later. So the data is there to support that this is becoming a little bit more popular. And maybe if it was a secret earlier this year and last year, the secret is quickly getting out. So this is something that we're keeping a close eye on. Health plans need to buy into this. That is the next major component. If the health plans buy in, that will accelerate the adoption into ICHRAs. As more tools become available for individuals to enroll in this individual coverage, for employers to set up these ICHRA plans, there's absolutely greater adoption on the horizon. This is all about the consumer experience. We talk about Consumerism 2.0. The superior consumer experience will end up winning out. As folks are going out and they're shopping for their health insurance and they're looking at their specific experience with ABC Health Plan, that is going to be a major component to Consumerism 2.0 and where this shift into the individual market lies. And we need to identify these distribution channels and technology enablers. So which partnerships will end up arising that will offer the best solution to further push the adoption into ICHRA and better this Consumerism 2.0 experience and really make it a reality. And as we continue to take things one day at a time in this very unpredictable world, there's one thing that we're seeing consistently, and that's a shift in healthcare towards consumerism. I feel like we're getting from Consumerism 1.0 into what we're defining here as Consumerism 2.0. And we've been keeping a really close eye on ICHRA for the past several months, and we'll continue to track it as we really feel that this is where it's going. As we see further stability in the ACA and the individual market, from the exiting administration to the new administration in the White House, all signs are pointing to ICHRA and consumerism being the central point to healthcare, with the end goal of making healthcare affordable, accessible, and plentiful for all Americans. I want to thank everybody for taking the time this afternoon to spend with us to talk about something that we are super passionate about. And I will pass it back to Ron. We'll take a few questions.
Okay, our first question today. Can you confirm if my understanding is correct, that the individual coverage has to be QHP certified, but does not have to be on exchange, correct?
Yes, that is absolutely my understanding. I know that we've worked with issuers that are providing off-exchange plans, but these are still QHP products. So your understanding is correct.
Okay, our next question. You had mentioned growth in the offering of ICHRAs, and while you showed metrics that imply more employers may offer, though I didn't see where you addressed the scale and potential growth of the ICHRA market. I've heard that the SCOTUS Texas versus California case and the pandemic had stifled potential employer shift to ICHRA. Curious on your thoughts.
Yeah, I think the biggest thing, there's been many distractions in 2020, as we can imagine here. And I think as we continue to navigate the next several months, and there's really not a lot of data that we have as far as what the numbers looked like in the open enrollment period that had just passed. So what I know we're very interested in is what was the adoption like for open enrollment 2021. As we mentioned, 2020 was the first time that it was introduced. There really wasn't a solution out there. Now that there's more solutions, we're going to take a close look at the metrics. And I think it was interesting the comment about California and in Texas. We're still seeing the shift from the FFM model into the individual states. And we don't feel that there's going to be pushback, if you will, at the individual state level. And just to further that point, I don't know if this is answering the question directly, but we're starting to even see that this whole enhanced direct enrollment concept is something that could apply to the state-based exchanges going forward. So the reason why I mentioned that is because through enhanced direct enrollment, you're able to do the subsidy validation on your platform directly without going to healthcare.gov. And in the state's case, you can't do it on your own platform. You have to use the state itself. So like I said, we're continuing to closely track the adoption, but we can say with certainty that there is going to be a greater shift from the employer coverage into the individual care. I hope I answered the question.
Okay. Well, that looks like that takes care of the questions for today. With that in mind, I'd like to thank all the attendees for taking time out of their day to join us. I'd also like to thank Kevin for a very informative and entertaining webinar today. Keep in mind that the slide deck and recording will be posted on the ACAP website by tomorrow morning. I'd like to hope everyone stays safe out there. Have a good day.
Thank you so much, Ron. Thanks, everybody.